Hello, everyone. We are going to go ahead and get started as people trickle in from the waiting room. Welcome to the 2025 Digital Health Summit brought to you by the California Telehealth Resource Center. We're glad you could join us for today's session, Inflection Point, Telehealth, AI, and Digital Health at the Crossroads, Policy, Payment, and Innovation in the Next Technology Wave. As you know, the theme of this year's event is Technology Supercycle Meets Healthcare, leveraging digital health services to combat the chronic disease crisis and other challenges. Before we begin, I'm just going to go over a few tips to help you navigate the conference. This session is purely for informational purposes. CTRC has no relevant financial interest or arrangement with any organizations related to commercial products or services discussed during the summit. Just a note that you do have to register to join each session. So if you haven't already, we do have one more session after this that I will be moderating. So I encourage you to go ahead and make sure you register for that one so you don't miss our last session of the day. And we will go ahead and drop that in the chat as well. On the next slide, you can use the Zoom functions to ask questions, post comments, and connect with fellow attendees throughout the session. So we highly encourage you to use that chat feature. The session is being recorded and will be posted on the CTRC YouTube channel by the end of the month. If you have any technical issues, reach out to a member of the CTRC team on the platform or contact us at caltrc@ocean.org. Lastly, we'd like to thank our funders, the U.S. Department of Health and Human Services and the California State Office of Rural Health for supporting the program and this digital conference. We also want to acknowledge the contributions of our co-sponsors, the California State Rural Health Association and the Insure the Uninsured Project. And with that, I will pass it to today's moderator, Sylvia.
Thank you, Rebecca. I am Sylvia Trujillo, Executive Director of the California Telehealth Resource Center, and I will moderate today's exceptional policy panel. Really excited about what is ahead of us. We will hold the last few minutes of today's sessions for Q&A, and I encourage you to go ahead and start dropping questions into the chat. So I just want to level set a little bit. We certainly are at a convergence point. Today's theme and our summit title is around the technology super cycle where AI meets bioengineering and Internet of Things. And while we're seeing a technological sprint never seen in human history, we also are having rapid changes occur with the new administration and with our Congress with regard to payment and regulatory issues. We're truly in uncharted waters where there's both risks and there's opportunities. And last, we're seeing, not surprisingly, a lot of activity out of our own legislature here in California, the Golden State, where certainly this legislature is a pace setter amongst all state legislatures in terms of digital health and AI and privacy. So I'm excited that today's panel is going to sincerely bring together national and state experts who are at the cutting edge of issues that are going to shape the way that healthcare is going to be delivered into the next, I would say, decades, if not century. So I'd like to start by introducing Lauren Ripplinger, who is the Chief Public Policy and Impact Officer at AHIMA. Lauren is architecting the future of health information policy. She is truly a convener of organizations and leaders in the Capitol. She ensures that we are able to unlock the power of data and that we do it in ways that serve patients, providers, and the greater good. I have seen firsthand how her work is laying the foundation for truly intelligent and humane healthcare systems that reduce burden and drive impact. Next, we have Alia Suleiman, who is a national compliance expert. She has unrivaled, I would say, insights into health information technology exchange, privacy, and regulatory affairs. And there's no question that she is widely sought for her expertise, both at the state and federal level with regard to healthcare AI. And I'm just going to say that one more time. It's Salomon. And I'm sorry about that, Alia. I need to get that right. And Alia really is the next generation of legal minds who is building the new frameworks that we're going to be working on. She is always ready with fresh insights about both federal and state opportunities and roadblocks in digital health. And she has been an exceptional steward in creating guardrails for both her clients and those that consult with her. Next, we have another legal eagle on our panel, and that is Rebecca Gwilt. She is a principal at Elevare, a strategic force who's reimagining how value-based care and digital health can transform lives. She works at really the intersection of law, innovation, and impact with innovators. And she too is building bridges where many see barriers. And I follow her and I get incredible insights from her work, not only in the areas of AI, but digital health. She is one of the first people I turn to when I want to know what's happening at the federal level for telehealth, remote monitoring, e-consult, and she has tremendous insights. And then our additional finalist, I'm not going to say last, our additional finalist is himself a powerhouse here in our Golden State with the legislature. He too has incredible insights, expertise, and tremendous regard in our state around what is happening in our legislature in all areas of healthcare, particularly as they impact hospitals. But he is part of key conversations that are happening in the state. And so I'm looking forward to the insights that he's going to bring to our discussion. So with that, I would like to turn it over first to Lauren. Our presenter, our panelists are going to do brief presentations, and then we're going to have a conversation and open it up for Q&A. So thank you all. So Lauren.
Excellent. Thanks, Sylvia, and thank you for that kind introduction. I just wanted to provide a little bit of background in terms of who AHIMA is, if you're not familiar with our organization, the American Health Information Management Association. We are a global nonprofit association of health information professionals. We see ourselves as the leading voice and authority on health information in healthcare today. And our mission as an organization is to empower people to impact health. So many of our folks work at the intersection of healthcare, technology, and business. So when you think about who our membership is, it often consists of medical coders, clinical documentation improvement specialists, directors and VPs of health information management, release of information specialists, as well as privacy, security, and compliance officers. Next slide, please. As Sylvia mentioned, I wanted to share a little bit about what is the current state of play at the federal level as it relates to AI policy. And I want to first start by talking a little about Congress. For folks that have been kind of tracking this lately, last year, the Senate and the House both formed working groups or task forces to develop white papers separately around what are the different ways in which government could think about oversight of AI, but also at the same time, really ensuring that innovation takes place. So these respective white papers came out. The Senate put theirs out first in May of last year. And then at the end of the year, the House put theirs forward as well. This was a really broad document, not just encompassing healthcare, but also included things like national security, our nation's infrastructure, those types of things. At the same time, at the end of last year, what was interesting is many of you all know there's been a lot of conversation around third-party assurance labs. And at the time, a number of members on the House side came forward and said, we have some real concerns about these assurance labs. Who was included in that group is now Brett Guthrie, who is the chairman of the House Energy and Commerce Committee that has jurisdiction over AI-related issues, or one of the committees that has jurisdiction, really, raised some concerns around regulatory capture that, big tech could kind of take advantage of these assurance labs and stifle innovation. So there is some skepticism on the Hill in terms of can industry really regulate itself in this space? Fast forward, Sylvia kind of hinted at this, the late breaking news on the Hill, as many of you all may know, is that the House passed their budget reconciliation bill in the early hours of this morning, 215 to 214, so very narrow margins. But what's interesting, though, is included in that particular bill is some text that would ban state and local governments from enforcing any laws on AI for the next 10 years. And our sense is this includes legislation that is currently already in effect. So this would include the California law that is currently in effect, the state of Colorado, et cetera, these types of things. And, Alia and others can kind of speak more as to what's going on in the lay of the land from a state perspective. What's also interesting about this provision is that it would not ban any law that is meant to facilitate the deployment of AI. So really focusing on how do we encourage people to adopt and deploy these technologies versus kind of having a broader oversight and regulatory framework. The other piece that's interesting about this bill language is that AI tools are very broadly defined to include things like automated decision systems. So there's this open question of, will this include tools that people have long used in the healthcare field that are perhaps like APGAR scores that are not necessarily considered AI tools today? While staff has said, technically this provision would not apply to laws that are technology agnostic, so state laws related to privacy, consumer protection, I do think there's a little bit of an open question. Now, the good news, I think for many would be that it's very unlikely this provision will make it through the Senate at this point. The Senate has a rule known as the Byrd Rule that basically says you cannot legislate on a bill that relates to the budget. They say it's non-germane. And so ultimately, I think the Senate parliamentarian who kind of rules on what's considered falls under the Byrd Rule, what doesn't, will be the ultimate decider of whether or not this provision actually stays now that it goes over to the Senate. So we do expect some pretty large changes around that legislation, but I think that's an important thing to call out. Switching gears, talking about the executive branch, many of you all have probably seen that the Trump administration repealed the prior Biden executive order related to advancing U.S. leadership in AI infrastructure back in January. And released his own that was really focused on removing barriers to American leadership in AI. So really focusing on that, how do we not lose ground in the AI space? Tied to that, there was a request for information that came out from the National Science Foundation and NIDARD of really asking the industry of what are the things that we need to do in order to maintain our dominance in AI innovation over the next 3 to 5 years. Many organizations responded to that. We're still waiting to see what the outcome of that is. And then in April, the Trump administration issued 2 memos from the Office of Management and Budget, which were really directives to the federal agencies around the use of AI. The first one was really focused around what are the things that federal agencies need to think about when it comes to the acquisition of AI tools. But for purposes of our discussion today, it's the second one that's really around accelerating federal use of AI that's perhaps more relevant to the discussion. And this included a number of different things like agencies need to appoint a chief AI officer. They need to think about, for high impact AI tools, taking a risk management based approach in terms of evaluating and ensuring that the use of those tools is proportionate to the risk involved. And they do call out certain healthcare AI tools, including medical devices, tools used for risk assessment or treatment, as well as the control of healthcare costs and underwriting. In addition to that, the agencies are really on the hook in a certain number of days to develop a strategy to remove barriers to adoption and responsible use of AI. Also thinking about what are the needs from a workforce perspective, both current and future employees within the federal government. So you see this focus really of continued innovation, and how do we deploy these tools for taxpayers. Next slide, please. So where are we at really from a regulatory perspective, in terms of who has jurisdiction over what? There's really kind of three buckets that we see right now within healthcare. The first is around the HHS Office for Civil Rights. Who is covered under that particular rule? This is really around providers, plans, those that accept financial assistance from HHS, to support decision making in covered entities and programs and activities. And what does that really mean? What do they have to comply with? They need to make sure that they're not using clinical algorithms in discriminatory ways. The Food and Drug Administration has kind of their own bucket of regulation. This is really around clinical decision support and device software function related guidance documents. These are really the folks that are manufacturers of device software functions. For example, AI-enabled software that meets the definition of a medical device. So they have to meet a certain standard there. And in that case, what do they need to do? They need to go through the regular FDA process as part of that to ensure safety and effectiveness. The last agency I'll mention is the Assistant Secretary for Technology and Policy, ASTP, also known as ONC. And their kind of jurisdiction is really around certified health IT systems. This came out of a rulemaking they did at the end of last year known as HTI-1. And really what they're on the hook for is that they have to provide a certain transparency requirements related to predictive decision support tools as part of, if they offer it as part of their health IT module. So really making sure they share data about what's the data they use to inform that tool, what is that synthetic data, how does it operate, those types of things for the end user itself. Next slide. The last thing I'll share before we kind of go to the next presenter, as Sylvia mentioned, we run what's known as the Health IT End Users Alliance. And this is a group of individuals that's dedicated to advancing end user perspectives in health IT policies and standards development. AAFP, AMA, OCHIN is a member of this wonderful group, as well as many others. But we recently released a consensus statement to help inform policymakers around what are the things they need to think about as they continue this discussion related to AI oversight and legislative frameworks. I won't go through all of these in the interest of time. I'll put a link in the chat for the full statement, but a couple ones I want to highlight is an emphasis on, the role of AI, making sure these tools augment and don't replace the end user's expertise. Regulation and oversight, making sure we're taking a risk-based approach to oversight and align these policies across the different federal agencies, but also ensure that the AI is developed in an ethical manner and responsible manner. Liability, which we know is a huge issue, ensuring that transparency can be a way of informing liability, and how do we balance the role of the developer versus the end user in the conversation. As well as end user education, participation, and leadership. How are we making sure we have specific and tailored education for end users and incorporating their feedback through the design, development, and implementation and post-market surveillance of these tools? And then I'll just highlight the last one is really AI use in payment and coverage activities. Making sure we have transparency and accountability when it comes to these decisions, but also ensure that the use of AI decisions don't increase inappropriate denials, unnecessarily delay care, or restrict access to care. So I know I ran through those updates quickly, but I want to make sure we get time for a discussion. So I will turn it over to the next presenter.
There we go. Good afternoon. Mark Farouk on behalf of the California Hospital Association. So CHA represents over 400 hospitals and health systems throughout California. So that ranges from what you typically see, the general acute care hospital with the emergency room sign that offers all the services, all the way to rehabilitation hospitals as well as freestanding psychiatric facilities. Next slide. So I wanted to talk about here in California from a legislative perspective and a regulatory perspective, kind of where we're at with digital health policies. And I think something that's been important, and we see a lot of in kind of hospital land, regulatory perspective, is a lot of things are operated in the healthcare space with regulatory flexibilities and waivers that are offered across a variety of different regulations and delivery methods. And so this is digital health is no different. They're absolutely at the federal and state level, these flexibilities. So we have some flexibilities under the Medicare program related to reimbursement. They're extended until later this year. We also have some as well at the state level that have provided some additional waiver flexibilities, providing the opportunity for rural health centers to be locations where those site providers can happen. Mental health teleservice is really a huge need in the behavioral health space in California, expanding flexibility to offer mental health services through telehealth. Not only because a shortage of providers overall, I assume not just California, but also in other states, but the ability also, we have a shortage in urban areas, but in rural areas, there's a shortage of every type of provider. And so, right, opening up the opportunity to have mental health treatment encounters occur through a telehealth system really is not just life-changing for those that need the assistance, but really life-changing for the providers that are able to provide that service and reach many more patients who may otherwise not have access to it. Uh, we have a full-time legislature, as many of you know, so we legislate a lot of things. But we're starting to see the emergence of more and more legislation in the telehealth area. So we do have some legislation to require DHCS to produce some reports about actual utilization. We think this is really helpful in seeing what's out there because it's good to have data for kind of the next step of getting the availability of telemedicine into more communities and opening up those opportunities. And then the AB 257 that I mentioned here, so it's called the Equal Access to Specialty Care Everywhere Act, but it establishes a project related to telehealth it creates a specialty care for network for safety net providers. And so again, trying to improve access to behavioral health services and other services in really those underserved communities. Now, of course, the backdrop of all this to really get these services into those underserved communities, particularly rural areas, is having that infrastructure, that broadband infrastructure to even make a lot of this possible. There has been a lot of investment from the state of California and at the federal level in the broadband infrastructure. And so it's promising, yet there is a cloud on the horizon. And so I don't want to be the Debbie Downer here to talk about the obstacles, but we have to kind of talk about what we've seen in the last week with the release of the governor's May revision, part of the budget. Next slide, please. So I think it's important to backdrop this discussion about telehealth, where we're at now, the future of that, and what it looks like given that we have right now a $12 billion budget deficit that we're trying to solve for. So the May revise that the governor put out earlier this week, or I'm sorry, last week, includes a lot of pretty aggressive cuts. And unfortunately, most of the solutions to the budget problem are occurring in the healthcare space. There's not a lot of as we say in kind of the in budget land, I do the budget advocacy work at CHA. There's only so many aisles you can shop on when you're trying to look at budget solutions. And unfortunately, for providers, healthcare is one of those places where there's a lot more, at least from those that are designing budgets, believe there's more flexibility to come up with budget solutions. And so I flag this because I think, these are things that will have short-term, medium, and particularly long-term impacts on the ability to expand telehealth, making sure we have that infrastructure. What do reimbursement models look like for telehealth? What reimbursement models are left? And so some really troubling aspects of what we've seen so far at the state budget level, right? Enrollment freezes, potential premiums for those with unsatisfactory immigration status, elimination of long-term care and dental benefits. Significant cost overruns have been identified in the pharmaceutical space, so ramping down on coverage of certain prescription drugs. And then, of course, a big investment that the voters passed last November, Proposition 35. Nearly 70% of California's voters voted for Proposition 35 to invest billions more into the Medi-Cal system. It really focused on provider rate increases in buckets related to specialty care, primary care, behavioral health. And these are places where telehealth can provide a valuable outlet to get those sources out to those underserved communities, a tool for providers that need additional tools in those communities. And unfortunately, the budget proposal, as we've seen it today, sweeps significant portions of that funding to backfill some care that's already been provided, as well as backfilling other parts of the Medi-Cal budget. And so there's some really significant headwinds that we're facing as a state. We have the short-term budget, but we also have long-term fiscal constraints as well. And then, of course, as referenced earlier, at the federal level with the passage of the budget funding bill, how is this going to impact California? And again, there's so much uncertainty in trying to solve the medium and long term. And so these are going to have significant impacts on providers, what providers are able to do, what access looks like, what is made a priority. And so I think there's always, the risk that policymakers, lose sight of the necessary investments they need to make in these tools. And then, we're also confronted with this is kind of an age-old thing that happens here in Sacramento, right? We're a state of technology. We want people to use more technology to streamline services, to find efficiencies, but then we want to put such significant regulation and constraints on that it almost becomes impossible to utilize the tools that we want people to utilize. And then another issue there that I didn't put it on the slide, but I was thinking about it. And I just wanted to mention it. We also have constraints related to the Office of Healthcare Affordability in California, which is putting spending constraints on what providers can spend, and that will also have potential impact. So I say all that to say, not to be a total downer on what the use of technology and telehealth means in California, but I think it's important to point out some of those headwinds, and I think there are opportunities though. The need is there. The folks, the patients that utilize these services, telehealth, the providers that utilize this, are the best storytellers. What we've learned at CHA is rather than folks like me telling the story, if we can get our actual providers that are in the community, if we can get patients to talk about this, they'll have a much greater impact on the outcome of policy than kind of, the policy, kind of government advocate side of the equation. And so being able to tell that story of just how impactful this can be on communities is really critical for the long-term future of this technology. And with that, I will pass it to the next presenter.
Thank you, Mark. It's nice to be here with everyone. I'm Alia, and I'm going to be combining some elements from Lauren and Mark's presentation. So Lauren covered AI policy. Mark went straight into the complexity of healthcare in California, and I'm going to try to combine those two to give you a perspective on AI policy in the state of California. But before I do that, I always like to level set whenever we're having a conversation about the policies or laws that apply to healthcare AI, that just like the major tech companies are racing to develop the biggest, baddest, greatest foundation model, regulators at the federal and state level, and sometimes even self-regulatory bodies are racing to create the rubric that we use to decide whether or not AI is responsible, trustworthy, reliable, and appropriate for various use cases. Lauren highlighted many of the tiles on this slide in her remarks, so thank you, Lauren. The thing I wanted to call out two things here I that we'll be diving into from a California perspective. So first, this whole idea of state medical boards and the role that they play in creating oversight or other responsibility expectations for how clinicians use AI in the practice of medicine. This is an evolving area of oversight, but it is absolutely an area of interest for state medical boards. And as we'll see in just a moment, California is a really good example of a state where state medical boards have really been empowered with enforcement authority when it comes to particular types of AI integrations into healthcare. So don't sleep on the California Medical Board and the Osteopathic Board. There's a lot of activity there that is worth tracking. The second thing I wanted to highlight is the state legislative activity that is coming up. And if we move to the next slide, we'll go a little deeper. So what do you get when you combine fear, hope, and a lack of comprehensive federal action on AI? My answer is state AI laws and oversight. And just to put this into perspective for everyone, in 2025's state legislative sessions alone, 45 states introduced 550 AI bills, and a huge portion of those bills had call outs to either the use of health information in AI applications or just general considerations about responsible AI governance. So calling out here that this is a huge area of activity. We'll see where that moratorium on state laws in the federal bill lands. But regardless of how things go, it is worthwhile to focus on the themes that states are focused on in these various legislative proposals. And if we move to the next slide, I want to highlight one example from California. So in January of this year, a new law went into effect. It was one of 18 laws that were finalized last year related to AI. And for perspective, 38 AI related laws went to Governor Newsom's desk and he signed 18 of them. So there's a big pool of new guidance out there, really new requirements out there when it comes to the use of AI in California. A chunk of those bills were related to AI in healthcare. This one is a really good example of a key theme that's coming up state to state, but definitely in California around transparency. What is the right level of transparency that healthcare organizations using AI owe to patients? And when should that transparency be made available? AB 3030 is, effectively taking the position that transparency should be context driven and while it doesn't ban AI, it does require disclosure when AI is generating a patient communication about clinical matters. And there's this really interesting exemption for when a human is actually reviewing the communication. All of a sudden you're kind of outside of this disclosure requirement if you've got a human in the loop. But this idea that you're going to include a disclaimer when a message is created by AI with the format variable depending on whether it's written, audio, video, as well as clear instructions on how a patient can reach a person about the message they receive. this, really is all about meaningful transparency to help folks know when they are interacting with a licensed clinician or provider versus anyone else. And the key thing I want to highlight here is that enforcement is through the medical boards. Like violations will go through the Medical Board of California or the Osteopathic Medical Board, the same bodies that handle other professional standards. And it just, again, goes to show states like California using the levers that exist to them to create, enforceable expectations in this space. And if you go to the final slide, on the theme of levers that exist, the California Attorney General wanted to remind everyone in California earlier this year in January, he released this legal advisory on how, hey, FYI, even though you're seeing these new laws finalized by the state legislature, there are plenty of existing laws on the books in California that apply to the use of AI in healthcare. This guidance is linked here. I'll also pop a link into the chat after my segment is up. But the key thing here is that there are a whole swath of consumer protection, civil rights, competition, privacy laws that apply to the use of AI in healthcare. And so we shouldn't operate with this attitude of AI exceptionalism, right? That all of a sudden AI is different and then only the AI laws really apply to responsible use of this technology. There are all sorts of transparency, oversight, and liability considerations that are going to continue to apply to the use of AI in healthcare, just like it would apply to the use of any software system, product, tool in healthcare. So really good guidance to get your arms around to understand how one of the biggest state enforcers is thinking about responsible AI oversight in healthcare. And with that, I will pass it on to Rebecca.
Okay. Hi, everyone. We really want to get to questions, so I'm going to make this as swift as I can. So I'm going to talk to you about federal telehealth and care management policy. So on telehealth in particular, we are rapidly approaching two major federal cliffs that have the potential to reshape virtual care if we should careen over them. I don't believe that will happen, but these are pretty important policy priorities for the industry, so that's where I'm going to start. So first, unless Congress acts between now and then, and I predict that it will, the Medicare telehealth flexibilities that were put into place during the pandemic will sunset on September 30th. These include key provisions like allowing the home as an originating site, coverage for audio-only visits, letting FQHCs act as distant site providers. The second cliff, the DEI teleprescribing flexibilities, they're going to end on December 31st. So without final action on the special registration rule, which came out in January, most providers across the country will practically lose the ability to prescribe scheduled drugs, Schedule 2 through 5 drugs via telemedicine to new patients. The proposed rule, whose comment period has long since closed, it included a number of policies that will allow teleprescribing of most controlled substances, but it will make it very difficult, except in the case of buprenorphine. If they move forward with the currently proposed rule, and there are some associations, including the American Telemedicine Association, that's calling for them to throw out that rule altogether because it's so problematic, which they did with the prior rule. If they move forward with it, what you can expect is a special registration process for teleprescribing that includes various categories of registration, prescribing limits, licensure exceptions, telemedicine platform registration. Practitioners have to be licensed in every state in which they teleprescribe to. There's geographic requirements which would be quite burdensome. There are going to be limits on the number of telemedicine versus traditional prescriptions, and some fairly impossible to achieve patient screening procedures. There is a new head of DEA. That person came from within the agency. If what I'm reading through the rule is correct, they are onto the fact that there are telemedicine platforms not sort of traditional hospital providers and things like that, that have played fast and loose with these rules and gotten in trouble. And I think that's been bad for the industry. They did sort of cherry pick the kinds of things that there was such outcry around, like children's psychiatry and things like that. But we are waiting for that final rule. And if it doesn't come out by the end of the year, some sort of extension. Here's the good news: federal agencies. Oh, next slide, please. Federal agencies generally don't need Congress to innovate around non-telemedicine services, and they are not pulling back from virtual care. If anything, I'm seeing CMS double down on communication technology-based services like RPM, virtual check-ins, RTM. They're not just surviving, they're really expanding and have been since they came out in 2018. Over the last few years, CMS has introduced new codes. So this is sort of an example of the expansion. Principal care management, transitional care management, chronic pain management, and in 2025, a per patient per month advanced primary care code. CMS has been collecting information about these codes for years and years. If they had the evidence saying that it didn't work or it was bad for the fisc, we would have seen a retreat. We're not seeing that, and I think that that's a good thing. But the other inevitable trend then is the shift from an era of expansion to an era of accountability. So CMS and OIG are increasing enforcement and time-based billings, like there is under the CCM codes and the RPM codes, will be under a microscope. The good and bad news is that based on what I have seen, the folks doing the enforcing really don't understand these care management services, and that's leading to enforcement actions that are pretty readily dispatched because there is no wrongdoing. It's literally a misunderstanding of what these codes do and what they're for. That can be expensive, but at least that means that there likely isn't widespread fraud, and that's good for the industry. The other exciting development, and this is a little bit of me reading the tea leaves, is that CMS may be signaling a shift to bundled and hybrid payments, which should make it easier to deliver care across multiple modalities. Part of the complaints that we've seen around the care management codes is that they are very prescriptive. The APCM codes, the Advanced Primary Care Management codes, in contrast, combine several different care management and communication technology-based services elements into a single monthly bundled fee. This, like I said, this is markedly different from RPM and RTM, for instance, that require a certain number of readings in a certain time period with a certain type of monitoring and a certain type of clinical staff, et cetera. The APCM codes, I would like to think, portend sort of a broader strategy that puts decision-making back in the hands of the doctors and is also a big opportunity for telemedicine companies, or could be if the reimbursement was a little bit more significant. So I'll be curious to see what comes out in the summer's proposed rule. On the legislative front, 2025 could be the year of telehealth permanence. I've been saying that for 3 years, so who knows? But it's a bipartisan issue. Lots of bills aimed at codifying the pandemic era flexibilities. On the digital therapeutics front, there's a new bill that would create a Medicare and Medicaid benefit category specifically for software-based treatments, and that's pretty exciting for the industry. There are some employer-focused bills with the high deductible health plan carve-out. That's been sort of a hit to the industry so far, and they're hoping to make some progress on it. All that to say, there's a lot of activity and bipartisan support, including executive support, which is obviously becoming more important these days. Support in sort of modernizing the country's telehealth and digital health policy. And if Congress can get their act together from the telehealth perspective, we may actually sort of see that happen this year. One of the most exciting things this year came just last week, not from legislation or regulation, but from an RFI, specifically focused on the U.S. healthcare technology ecosystem. I checked just before this meeting, and there are 30 comments already. So here's the deal, and I think it's pretty historic. CMS and ONC jointly have asked stakeholders how those agencies can reduce barriers to innovation and support the adoption of patient-centered digital tools. They specifically called out digital health products and the digital health ecosystem. They specifically discuss health management and care navigation. It is true that the RFI focuses a great deal on interoperability. I'm sure Alia and Lauren have dug deeply into it. Certified EHR tech, that kind of sort of more traditional health tech focus, but they are speaking directly to the industry in a way I really haven't seen before. They're not just saying how we can, how can we improve this thing, this policy that we have put together that exists that we're proud of. They are saying how can they help advance healthcare tech in this country, and if they're a barrier to it, they want to know. So I believe this RFI is an open door for telehealth platforms, RPM vendors, care navigation tools to really influence federal strategy. And that's not just policy, that's a sea change. And together with RFK's Senate testimony last week, I really do think that the HHS as an agency believes that tech-enabled care is the future, and will be key to managing healthcare costs nationwide, which I think is very, very cool. And I'll just close up by saying, the clock is ticking on both the Medicare and DEA cliffs. Stakeholders should act now on that through engagement, advocacy, preparation. Second, if you build or deliver digital health tools, please respond to the CMS RFI. I'm going to have a collection tool that I'm putting out tomorrow to work with ATA to gather as many comments as possible. You can look for that on LinkedIn, but that's really your chance to help the rules of the next era here. Sylvia talked about this a little bit, but I do believe this is as Biden would say, a big fucking deal. So the last thing is expect enforcement. If you're billing time-based codes, your documentation needs to be airtight. And finally, start rethinking your strategy for a world in which both the regulatory agencies and industries believe that digital health isn't just sort of a one-off. It's really going to be part of the core infrastructure of care delivery in the country moving forward.
So I am going to have you all back for a part two fireside chat. We have reached our time, and I want to thank all of you for the incredibly rich content. Not only are we going to send out this on our social media, and I'm going to have my slide master keep moving the slides forward. We are going to launch our survey right now for our participants. And if you feel like we gave you an appetizer and there's more deliciousness to come, you're absolutely right. This is an incredible crew of experts that have provided us with substantive information that is literally off the hot press like hours ago. And Rebecca, in terms of you and Alia, the depth of content and comprehensiveness, and similarly, Mark, really knowing what's happening in the capital of our state and the legislative environment, as well as the challenge. So Rebecca has outlined, I think, with the tremendous enthusiasm that I also feel, the opportunities for digital health and AI. On the flip side, I am painfully aware of all that Mark has detailed with regard to the scarcity environment we're in. And that really comes back to we're in a technology super cycle. We are also at the cusp of a extreme scarcity environment and really trying to find where those opportunities are to drive efficiencies and do transformation. And so we are going to have you guys back if you're willing to come. Lots of interest out there. And so I am going to go ahead and have our slide master advances to the AI boot camp. And I want to thank our panelists. We really appreciate all that you have contributed here today. It's incredibly rich. And in that vein, we are getting ready, stakeholders, for the innovation transformation that's coming. So we, along with a large number of other TRCs around the country and centers of excellence, as well as California-based organization like the California State Rural Health Association, will be hosting an AI boot camp. We'll be kicking off the registration in June and activities in June, July, and August, and we hope to see you there. So with that, we're going to give it a wrap. And we really thank you and appreciate you. And we look forward to seeing you all in the next session.